Okay, so I guess moving along with a great day, I'd like to introduce our first speaker. It's Dr. Parneet Chima from William Osler Health System in Toronto. So thank you. She'll be talking about early stage ALK and EGFR altered non-small cell. Are we driving for cure or managing a chronic disease? I guess you'll tell us.
Very good question. So let's get at it. So thank you so much for the organizers and John and Norma for inviting me to give this talk. Here are my disclosures. After this talk, we'll be able to highlight key practice-changing trials in the management of early-stage EGFR and ALK non-small cell lung cancer, and we'll be able to interpret and reflect really on the long-term outcomes of these pivotal trials. So are we driving for cure or managing a chronic disease? Okay, to start that, when I looked at this question, I said, okay, well, let's look at the definition. What is the definition of cure? And actually, there's many definitions out there, but there's a charter of a group of physicians that came together and looked at cancer in 2014, published their I can't see that slide either, published the definition of being the life expectancy is the same as sex or age match a general population. So that would be considered a statistical cure. I think one of the key things that's highlighted out of this paper that I want everybody to keep in mind when we're talking about stage 3 non-small cell lung cancer is some cancers cannot and should never be defined as cured because stage is too advanced, cure rate too low, or risk of recurrence is too high. But I think from a practical perspective, many of us oncologists think of it as, can we stop anti-cancer therapy and have the same life expectancy? In terms of chronic disease, no definition for this, but we can think of personal cure when a patient dies from other causes, irrespective if they have cancer there or cancer not. From a practical perspective, when I'm talking about cure today, it would be non-small cell lung cancer controlled on the TKI and delayed terminal diagnosis, but if we were to stop that TKI, their disease would grow and progress. So obviously there's terminal diagnosis, clear definition, it cannot be controlled, it can lead to death. But what we're trying to do is create this evolution into a chronic disease. And in these buckets of cure and chronic disease, having these long-term survivors. So should we really be saying, how do we create these long-term survivors, understanding some are cured and some have a chronic disease? Well, is early-stage resectable non-small cell lung cancer a curable disease? This is real-world data looking at Canadian data through the Paleos database, looking at EGFR-positive lung cancer that was resected, and those with stage 2-3 at 4 years was 17%. And the ADORA trial in stage 3 was 16%, so very similar. And those patients from the MGH and MSK database from ALK-positive patients with stage 3 disease, invariably, most patients are not cured from their cancer, so extremely poor prognosis. So let's look at this in the context of the ADORA trial. So adjuvant osimertinib for 3 years in resected non-small cell lung cancer with EGFR mutated. You can see that at 3-year mark, the curves are starting to come together, but there's a significant improvement of progression, disease-free survival. When you look at the overall survival, interestingly, as time goes on, the overall survival improves. But what you can see is patients are recurring, and they're still living, but they're living with recurrent disease. So now, how do we actually define who's actually these patients that are recurring? Heather Wakili did a really good job looking at discussing this already. But in the updated ADORA trial, they looked at the ctDNA for MRD. So this is not just doing EGFR testing on blood, looking at variant allele frequency. This is a tumor-informed MRD, so we can't just start this tomorrow, is the bottom line. But it does inform us of a few things. So let's look at the data. Looking at those patients that were on osimertinib, there's 8% of patients that just don't do well. They recur regardless of being osimertinib, but there's 17% of patients that actually became MRD positive or had a disease-free survival event after stopping therapy. So is there a possibility that this is a chronic disease for these patients? Are we curing patients? You can see that blue graph where there's no MRD and there's no disease-free survival, that's the section that we're potentially curing patients. One of the best data from this, and it's a small group of patients, but really interesting data, is 5 patients had MRD positivity on osimertinib, and 4 of them cleared their MRD, but when osimertinib was stopped, all 4 of them actually had an MRD positivity in the future. So there are patients that we are in fact having a chronic disease. Osimertinib suppressing those patients, when we stop the drug, their disease recurs. And the MRD lead time, as we talked about, that was mentioned earlier, was 4.7 months. If you had MRD positivity, a disease-free survival event would be 4.7 months later. So interesting data, and I think we should just work on this to really get somewhere. We can learn a lot from these curves. So this is the ADORA updated disease-free survival and MRD event-free survival curves. 3 years of osimertinib. So what happens in these curves? You can see that there's a group of patients that most likely will go into the bucket of terminal disease. And so is there an opportunity to escalate therapy? Maybe AMI-laser in these patients, combination osimertinib and chemotherapy together opposed to sequentially. This is what we need to look at in the future of how we can change that. There's a group of patients that you can see all those hashtags there that are recurring and recurring fairly quickly after osimertinib is stopped. So is this patients that are chronic, and should we ask the question, are these patients that need indefinite osimertinib? And what we can say, I can say from the data now, those patients at MRD baseline that are about to go on osimertinib, we can say that most likely they're not cured. They're going to recur with their MRD positivity when we stop osimertinib. Then the question is, are we curing patients? There probably is some subset of patients that we are curing, but we won't know that data until, I would say, 5 years out. So you can see I extended the graph, because that is what we would say 5 years post-stopping osimertinib, to really identify what that gap of what patients we are actually curing. But then the question for that group is, do we actually need 3 years? I mean, to my knowledge, I don't necessarily think we need 3 years to kill a cancer cell. If we're going to kill a cancer cell, we probably would be able to do it in 6 months, 12 months. As shown in, there was a data looking even at a first-generation EGFR TKI with shorter duration of the EGFR TKI that had good outcomes. But I think really there's this, we need to work on this MRD ctDNA technique to even figure out who are those long-term survivors that if you have MRD positivity, can we intervene earlier to reduce morbidity of radiographic and symptomatic disease? Because unfortunately, these patients, they recur within the brain. And we know that has considerable morbidity, and you can see the disease-free survival after the 3-year mark when osimertinib is stopped, that patients are recurring within the brain that potentially we can prevent if we do some sophisticated testing. We can do the same exercise with ELINA. So looking at adjuvant alectinib for 2 years after resected stage 1B, 3A non-small cell lung cancer with an ALK rearrangement. Again, this difference in this trial, no patients had chemotherapy, but there was a lot of discussion that we would still recommend chemotherapy for these patients. But what happens after the 2-year mark? Well, it's really, really early data. We actually don't know. We can see that there's nice separation of the curves again while patients are on the alectinib, but when they're stopped, there is disease-free survival events. We need to see the long-term data to understand if 2 years of alectinib is not. We can't rely on overall survival. It's going to be very difficult to show an overall survival in this study. We know we just saw those large graphs in terms of crowns showing long-term survivals, but if you look at those patients that had post-recurrence and subsequent therapy, 37 out of the 38 actually went on to have an ALK TKI. So unlikely we're going to show an overall survival. But what's happening with these patients? That yes, they're living, but there's 2 states of living. You can live with no evidence of disease, or you can be living that you've recurred and potentially in the brain, and you can see that there's a lot of recurrences within the brain that are occurring, or the bone, that are no longer curable. And I would ask you, if we asked our questions, do you want to be a long-term survivor in early state, or do you want to be a long-term survivor that had recurrence and advanced stage disease? I think we probably would know what the answer would be from our patients. So one of the trials that's looking at is the length of therapy enough. Is 3 years of osimertinib enough? There's the Target trial. It's a single-arm trial looking at 5 years of osimertinib to see what that ends up being in terms of outcomes. But my thing is this the right question? If we're going for cure, is 3 years or shorter enough, I would argue is the question. If we're going for chronic, if we're admitting that some patients are going to have chronic disease, we won't be able to cure their therapy with osimertinib, should we be looking at indefinite osimertinib for that cohort of patient? But the key here is being able to identify who are those 3 buckets of patients. In terms of unresectable non-small cell lung cancer early stage, is this a curable disease? And looking at data from Pacific and the EGFR mutated population, looking at the global retrospective study of 17 institutions with ALK positive non-small cell lung cancer that had unresectable non-small cell lung cancer treated with chemoradiation, you can see that the outcomes are extremely dismal. Most patients we are not curing. So for most patients, this is not a curable disease, and a small subset of patients that this is a curable disease. The progression-free survival is anywhere from 7 to 10 months. So if we look at the LAURA trial, this is interesting. So LAURA was a chemoradiation followed by osimertinib, but the design accepted the fact that this was a chronic disease and not a curable disease, and continued osimertinib indefinitely or until toxicity. There is a crossover design as well. 81% of patients crossed over in the placebo arm. So when we look at this graph, there's extremely important progression-free survival. The graphs separate tremendously that we're delaying onset of progression or death by putting patients on osimertinib. And the survival, it's a bit early to see if we're going to be able to technically cure those patients. But we can see here that, again, there's still disease-free survival events, even though the overall survival is the same. In those patients that did not have osimertinib, you can see that they've progressed. So they're living in a state where they have bone metastases, brain metastases, as you can see as the new sites of area of metastases. So when you look at this graph, there's this whole area of, yes, maybe we're not curing those patients, but during that period of time, that blue area, we've significantly reduced the morbidity of patients by accepting that this is most likely a chronic disease for most patients opposed to a curative disease. And then fingers crossed with long-term outcome, will we see a tail of the curve, and patients that we are cured, personal cure. They're going to die from a different, from not their lung cancer. They may not have cured their lung cancer. So can we evolve this terminal disease into a chronic disease? So the next study that's looking at ALK-positive non-small cell lung cancer in the same setting is the Horizon 1 trial. It's a phase 3 trial looking at chemoradiation for ALK-positive patients, followed by alectinib for 3 years only, followed by compared to durvalumab. So we'll get some interesting data on stopping treatment for 3 years with a TKI versus the LAURA trial, which was indefinite. One of the questions came up about neoadjuvant. I think this will be really helpful to understand what patients maybe we can identify that are going to be in that potentially worse outcomes of terminal disease in the early stage versus chronic versus potentially cured. And one of the important, I think, arms in this is actually not just osimertinib neoadjuvantly, which we know does not generate as high PCR rates, it's 0 to 15%. But it can downsize tumors. But really this osimertinib and chemotherapy combination, I think that will be an interesting arm to look at and what the outcomes would be with that. And there's some smaller trials looking in the perioperative space with alectinib. So in terms of summary, are we curing patients with advanced, with EGFR non-small cell lung cancer and ALK rearranged non-small cell lung cancer with adjuvant consolidation TKI? Likely yes, but how many of these patients are we actually curing? It's really to be determined. We actually don't know yet. The long-term follow-up is going to be critical for us to be able to see what those curves look like with ADAURA, ALINA, and LAURA. Are we evolving patients at risk of a terminal disease to a chronic disease? Likely, yes. And I could say, with the data we have, MRD at positivity at baseline, we're probably looking at a chronic disease. And I'll probably put in this bucket, we probably should be thinking of unresectable stage 3 as chronic. Most patients with stage 3A resected, the outcomes are so poor that maybe this is a chronic disease as well. And so in terms of cure versus chronic, I'll rephrase that. How can we achieve long-term survival with minimal morbidity, living in a state of minimal tumor burden from their non-small cell lung cancer as well as toxicity from their anti-cancer therapy? There's role of, I think that MRD is really interesting, this looking at ctDNA to help us define that long-term outcomes from these trials, but also the neoadjuvant data will help us answer some of these questions. Thanks.
Parneet, do you want to stay up? We'll maybe take it. We won't do a panel for this one. We'll just go with questions.
So sit down. Oh, there's no panel.
So one of the questions that comes up, especially when I see the ALK data from ALINA, is just how common systemic disease is. If you look at the control arms, even the 1Bs, almost half have progressed by 2 or 3 years out. What do you see and we'll talk about this in the next session a little bit, what do you see the contribution of local therapy in this setting? It almost feels like if you were just to treat them with alectinib, you'd get the same outcome as whether you'd operate on them or not.
Yeah, I think if you look at both graphs for EGFR positive as well as ALK positives, the 1Bs, it's 50 to 70%. Like the outcomes are not great. One of the questions for stage 3, I think, is going to be a question is, and this is a practical question, if you have somebody that has stage 3A disease, that has EGFR mutated, are you going to give them chemoradiation followed by indefinite osimertinib, and you have access to indefinite osimertinib, or are you going to have them have a resection with only 3 years of osimertinib with a risk of recurrence and morbidity? That's one question, right? So how do we approach that? We've always approached stage 3 as, is this resectable? But as the surgery is the question. But should we be changing that to saying, what is the systemic therapy that's going to be the best long-term survivor, going to lead to the best long-term survival outcomes? We may not cure, but what's going to lead to that at 5-year mark where patients are living well, minimal morbidities from the treatments that we've given them?
fair enough. Any other questions from the audience? No? Okay. Thank you so much.